So thanks for being here for the first session on Saturday morning. We're going to talk about the small renal mass this morning, and I'll just personally on a note, my first talk at the KCA was about active surveillance for small renal masses, which was more years ago than I want to admit to. And I remember after that talk, a bunch of medical oncologists who will remain nameless coming and say, wow, I didn't realize you could watch small kidney tumors or small kidney cancers. And it's amazing to see kind of where we've come in the field. And so it's really exciting to be talking about how we're managing them today. So we've got two, do you guys have slides up? Thanks. We have two formats today. First, we're going to start with a debate. And I want to thank Brian, first of all, for helping me kind of coordinate this. We put him on the podium so he has to talk, so I get to stand here at the podium and do everything else. But we'll talk about the small renal mass. We'll talk about the nuanced conversations in that disease, and we'll talk about how active surveillance has now really emerged as an initial management strategy for many patients. And we're really going to focus that first debate on what are the triggers for intervention for patients who we start on surveillance. And so that debate will be with Maxine Tran from UK, Brian Shook here from UCLA, and Eric Kaufman, who's going to be joining us remotely to do that. And that'll be followed by a tumor board where we'll talk about quite a few patients with small kidney tumors and small renal masses and how we think about those. So with that, we'll get started, and Dr. Tran.
Thank you. That's great. Thank you very much, Phil. Good morning, everyone. Thank you to the planning committee for this amazing opportunity to be involved in such a great program. So I'm going to make the case for tumor size as a trigger for intervention for patients on active surveillance. Is it this one?
Yeah, should be.
Okay. So the learning objectives is to give a brief overview of the evidence that tumor size matters and how we can use this information to guide our management and our counseling of patients with a small renal mass. So I'm just going to focus, I've only got a few minutes, so I'm going to focus on two main papers. This is a paper from MSKCC that looked at tumor size and its association with malignant potential with RCC. Quite a large study, 2,675 patients. These were patients who were surgically treated, so all sizes basically. And in that population, 12% were benign, with 88% having a form of renal cancer. And what they found was that in about a little bit over 1,200 of those patients were T1A tumors. And what they found was with each 1 centimeter increase in size, this was associated with approximately 16% increased risk of malignancy. And when they looked specifically at clear cell renal cell carcinoma, they found that each 1 centimeter increase in size increased the odds ratio of having a high-grade disease. So that's defined as Furman grade 3 or 4 by about 25%. And interestingly, none of the ones that were treated surgically, if their tumors were less than a centimeter. I'll just caveat that this is quite kind of historical data from the 1990s to 2000, where I think nowadays we won't get that kind of surgical pathology of patients less than a centimeter tumors being treated surgically. But anyway, in that series, small numbers of patients who had a tumor that was less than a centimeter, none of which were high grade. So these were the tables from that study, just indicating that the smaller the tumor, the increased risk, the increased probability that tumor is going to be benign and also is going to have a low-grade disease. And what they found in tumors that were less than 3 centimeter size, there's about an 83 to 100% chance of being low-grade if it is a form of clear cell renal cell carcinoma. The next study I'm just going to spend a couple of minutes on is a bit more recent publication from the Mayo Clinic. They went a step further, again looking at surgically excised tumors, PT1 to PT2, but they looked at aggressive features, and they defined this as either high-grade clear cell or high-grade papillary cell, collecting duct RCC or translocation-associated RCC, HL-RCC unclassified, or malignant non-RCC. and also aggressive features such as coagulative necrosis or sarcomatoid differentiation. Again, a big series of patients, over 2,650 patients, around 1,300 of which were T1A tumours. And what they reported was that the 10-year cancer-specific survival for an indolent tumour, so those which didn't display any of those aggressive features previously defined, was very good at 96%. This was reduced to about 81% for those with aggressive features, and there was a significant correlation with size. The figures are slightly higher than the series that was presented from the MSKCC. So tumours around 2 centimetres or less, 84% of those would be malignant, with an 18% likelihood of aggressive histology. Those between 2 and 3 centimetres have slightly higher increased risk of being cancerous, with 24% likelihood of aggressive histology. And those between 3 and 4 centimetres, 80% risk of cancer, with a 29% likelihood of aggressive histology. But obviously, both of these studies, are limited with selection bias. These are all surgical pathology cases, and I'm sure the other speakers will be talking about those who have been on active surveillance who weren't treated surgically. We'll make the case for that. So what does that mean for my practice on Monday? I think it just reiterates that tumour size is a very important factor when counselling patients diagnosed with a small renal mass. Just in simplistic terms, when counselling patients, a little less than 1 in 5 patients with a small renal mass less than 2 centimetres will have aggressive features on histology. I think that's pretty useful. Around a little less than 1 in 4 patients with a tumour between 2 and 3 centimetres will have aggressive features, and about 1 in 3 patients with a small renal mass between 3 and 4 centimetres will have aggressive features. And I think this is just highlights and supports that active surveillance, at least initially, is a safe management strategy in the majority of patients diagnosed with small renal mass. Thank you.
Thank you, Maxine. And now we have Dr. Kaufman's video, please.
I want to begin by thanking the KCA Planning Committee, as well as my co-debaters Brian and Phil, for inviting this talk, and I'm truly sorry I could not be there today in person. My talk will argue the importance of a rapid growth rate in triggering treatment during active surveillance. Learning objectives include to name the growth rate threshold that is most commonly used to classify renal mass growth as rapid, and secondly, to name 2 adverse oncologic outcomes that are frequently associated with rapid growth. With accumulating evidence for oncologic safety of active surveillance, the pendulum has swung over the past 2 decades, such that delayed intervention, or DI, is now being driven less by patient anxiety and more by objective tumor features. But what specific tumor features should we be using as triggers? A greater than 4 centimeter size cutoff has provided a foundation for triggering DI, but the red flag here is the roughly 2% of SRM patients who we know from the surgical literature will metastasize without ever meeting this size threshold. Thus, we must look for other tumor triggers to identify and treat these 2% high-risk cases. Our outstanding Roswell Park Fellow, Muammar Altak, and I recently reviewed all reported active surveillance series with at least 50 patients, as published in this comprehensive multidisciplinary kidney cancer textbook edited by Raina McKay and Eric Singer. As you can see in this table, the progression criteria used by different institutions for triggering DI vary widely, contributing to highly variable DI rates that range from 5% up to 40%. Thus, there is a clear lack of standardization here to overcome. So before we delve into why growth rate is a useful DI trigger, let's review some growth rate basics. The median SRM growth rate is only 1 to 2 millimeters per year, and 1 in 3 SRMs lack growth on surveillance, at least in the short term. While growth rate reproducibility has been challenged, these findings are highly consistent across different high-volume surveillance centers, as illustrated by the marked similarity in these growth rate waterfall plots, with Mike Jewett and Tony Finelli's Canadian consortium on the left and our Roswell Park cohort on the right. The most commonly used cutoff for rapid growth is greater than 5 millimeters per year, which is several-fold higher than the median and detected in about 15% of SRMs. Although we at Roswell use size-stratified cutoffs, in which we switch from 5 millimeters per year to a presumably safer cutoff of 3 millimeters per year if the tumor is over 3 centimeters. So let's jump into 3 key reasons why a rapid growth rate should trigger DI. First, numerous studies support that rapid growth indicates a greater chance of underlying adverse pathology. And while high-grade or T3 tumors make up only 15 to 20% of the SRM pool, they are precisely the tumors that we don't want to be watching due to higher metastatic risk. Secondly, and more compelling, there is even a direct association of rapid growth with metastatic potential. Again, with numerous references to support. Finally, if that's not enough to convince, there is a third reason, which I call the writing on the wall reason, which is that rapid growth also predicts imminent progression based on tumor size. In other words, a 3.5 centimeter tumors with growth rate of 8 millimeters per year is almost certainly going to progress based on size over 4 centimeters within the next 6 to 12 months. Hence, the writing is on the wall, so why wait to treat and chance the unnecessary metastatic risk? And while one may argue that some references on my prior slide might have had biases due to retrospective measurement of growth rates, several other of these studies in fact prospectively measured growth rates to guide clinical decisions during surveillance, one of them being our very own Roswell Park experience. Of note, the Roswell cohort is unique in that the vast majority, or 97%, of all non-hereditary SRM patients underwent active surveillance rather than immediate treatment. The cohort is also unique in that DI was triggered only if a patient met one of these prospectively defined progression criteria summarized here by the GLASS acronym and using the predefined cutoffs listed below. Of note, a rapid growth rate was defined using size-stratified thresholds as mentioned earlier. On our most recent reported analysis, most patients avoided treatment and there were no metastases. Importantly, 98% of delayed interventions were triggered by tumor factors rather than anxiety alone. And rapid growth was by far the most common trigger met. With growth rate thus driving treatment, we found that most or 60% of our DI resection cases had adverse pathology, much higher than the usual 15 to 20% rate of a typical SRM population. Thus, prospective use of a rapid growth rate trigger was able to selectively treat SRM cases with high-risk pathology while leaving most other SRMs alone. And apologies to co-debater Dr. Shuck, but while all adverse pathology tumors did have pre-op biopsy, unfavorable histology was detected on that pre-op biopsy in only one case, supporting that biopsy, while highly specific for adverse pathology, does suffer from low sensitivity in SRMs. It bears emphasizing that rapid growth predicts more likely metastasis, even among smaller tumor sizes. Dr. Smaldone and the Fox Chase team's pioneering review of nearly 1,000 surveillance patients showed us that metastatic SRMs have a median growth rate of 6.5 millimeters per year, several-fold higher than non-metastatic SRMs. Our Roswell Park team recently published a comprehensive list of all metastatic non-hereditary SRMs reported with both growth rate and size at metastasis. Metastatic cases all showed above average growth rates, and the vast majority surpassed 5 millimeters per year, providing compelling evidence for the clinical significance of a rapid growth. In several cases, the tumor was not yet even 4 centimeters when it metastasized, but again, the growth rate was rapid in each case. Thus, a rapid growth trigger could have treated these smaller tumors and perhaps prevented metastasis. Now, while some reports have noted fluctuations in a patient's growth rate during surveillance, thus challenging reliability, this is not something I commonly encounter in my own practice, and suspect it may reflect common use of ultrasound, which lacks precise millimeter resolution to determine growth rate over short intervals. The solution, in my opinion, is to utilize initially cross-sectional imaging to trend out small millimeter level changes and to reserve ultrasound until growth rate is then better established. Secondly, one should have a second check method routinely in place, whether it be an independent radiologic review by the urologist or second radiologist, or simply measuring the second and third dimensions to ensure they follow the same growth rate trend as the first dimension, or even just a short interval confirmatory scan. In these ways, growth rate can be reliably monitored. Before we conclude, let's virtually poll the audience as to which of these two tumors to convert to DI, if you could choose only one. Based on size alone, the decision is obviously option A, since this tumor has surpassed the 4 centimeter cutoff to trigger treatment. But what if I now provide growth rates from the past 18 months? We now have a 4.1 centimeter tumor with a 0 growth rate versus a 3.6 centimeter tumor with a consistent 8 millimeter per year growth rate, which is in the top 10 percentile of SRM speeds. If you now chose option B, you have delighted myself, but sadly disappointed Dr. Pierorazio by agreeing that growth rate should trump size for triggering DI. In conclusion, rapid SRM growth should trigger treatment due to increased risk for adverse pathology and metastatic potential, while slower growth portends a negligible oncologic risk ideal for continuing surveillance. Thus, when measured accurately, growth rate improves SRM risk stratification and should be incorporated into your surveillance practice on Monday. As a parting disclaimer, I just want to add that I myself use not only growth rate, but also size and histology in complementary fashion. And therefore, I really think that there are no losers here in this debate and that we all deserve medals. It's just the color of those medals may differ. Thank you.
Okay, well, Brian Sharp from UCLA. I do fight dirty, and it's good to go against Maxine, who's a good friend, and Eric Kaufman, who's one of my closest friends and former co-fellow. I wish he was here. But I'm going to explain why they are very confused and why histology really matters, and hopefully we can educate them. So is biology destiny? So here's a picture of Bronny James 20 years ago. And you could have predicted with his dad and his biology, he was going to probably end up to be a star. And look at him on the Lakers. Unfortunately, he was dropped to the D League a couple days ago. But he has good genetics, and you would expect that potentially he'd be a good athlete. Well, there's me, who was a 5'10", former high jumper, okay, not the best. And there's my son, and his mom is 5'1". And it's not looking good for the NBA, maybe for urology, but our genetics are clearly different than Bronny James. So we're going to talk about, histology. I'll explain why I'm correct, why Dr. Kaufman talking about growth kinetics and Dr. Tran about size, explain why they're confused. I think they had a little too much bourbon last night, so we'll explain why. So, Maxine's favorite basketball player is Sean Bradley. He was 7'6". He was horrible. He averaged like 2 points a game. One data point. She thinks she can predict the future, so she invested all her money in his gear. But, I know we checked her Netflix on the way over, and she watched this great movie, My Giant. You thought there was a great giant in there, George Mulrazian, and it wasn't a very good movie, but he's a gentle giant. He's big, but actually not that exciting. Now, Eric invested all his money in Peloton. He thought he could predict the future with 2 different data points, and unfortunately, Eric's not doing well. He actually moonlights driving Uber. And he's as trustworthy as a weatherman. I never trust Eric's opinion going out to lunch because he said, I went to this restaurant twice, it's pretty good, and their health rating's not very good. So I don't trust Eric very much, and he thinks he can predict the future with maybe 2 measurements. So simpler times, this is a slide from now, 2012, where we had, before the last 2 WHO data points. I thank Yingbei and her colleagues for making our field much more confusing, but obviously helping us. But now, obviously, there's over 20 different subtypes with the last 2 WHO. It's very confusing, and biology is obviously very different. Now, this is how, we sometimes treat patients. We see size and shape, and, we shouldn't apply management strategies based on these different size and shape fruits. Eric and Maxine think that's what we should do. But I would say that our goal should be matching treatment intensity with disease biology. And we don't have the greatest biomarkers, but, subtype is a biomarker of potential outcome. And we do know that things like collecting duct are obviously much more aggressive than things like oncocytoma. And I would stress that any patient who has higher procedural risks should be characterized. You can characterize them early, or you can characterize them late. So maybe watch them, see what happens, but characterize them now or later. Okay, one of my favorite candies. Now, Maxine and Eric will tell you, there are tumors that are shark, scuppy, and goldfish, but that's fake. A shark is still a shark, whether it swims fast or slow. A shark is still a shark, whether it's a big shark or a small shark. okay? Whether it lost a couple teeth, it still is a dangerous animal. And their subtype clearly impacts aggressivity. We have obviously some sea cucumbers as well in there, and there's a whole different, basically level of aggressiveness of a lot of these different tumors. And we do know histology predicts behavior, different subtypes, different propensity to spread. This is work from Gennady looking at SEER, looking at Tony and Mike's work from biopsy series in Toronto. Clearly, there are different types of tumors. Clear cell grows faster than papillary or chromophobe. So we can characterize these. Looking at Eric's own data, he said, oh, tumors progressed, delayed intervention, I'm going to follow prospectively. But the majority of those tumors were clear cell. So 86% of the tumors in his prospective study were clear cell. Those are the ones that progressed. Now, we can diagnose clear cell. So this is the girentuximab scan we've heard about. It's just published in Lancet Oncology. Great. Effective, clean, hopefully will be available for our patients to detect clear cell. Now, we also know Ivan Pedrosa has been pushing the clear cell score, done great work out of UT Southwestern. You can characterize multiparametric MRI, and it can also predict for maybe growth or aggressiveness in the future. Now, we also know that there are oncocytomas, oncocytic tumors, hybrid tumors, low-grade oncocytic tumors. These in generally grow slower, and we have sestamibi scans. This is a patient of mine who was super anxious. We got the scan. We were confident it's an oncocytic tumor, probably grows slower. This is great. I could predict that he was not going to do poorly, so I characterized it early and followed him. Now, biopsy obviously has not been discussed that much, but clearly the positive predictive value is great. We're 80% accurate at predicting histology. It doesn't make surgery more complicated. It doesn't make tumors spread and seed. That's just like a myth. Yeah, maybe a cell gets into a fat. Who cares? It doesn't cause it to change prognosis. It doesn't increase local recurrence rates. So just in final thoughts, just looking, it came out wrong, but my son on the growth curve, he's actually at 90% in height, and that's just one snapshot. I don't think he's going to end up in the NBA, and the growth curve, these are just skewed a little bit. He's doing well with the trajectory, and I don't think he's an NBA star. I think he hopefully will be a future urologist or medical oncologist, but don't be fooled by one or two data points, and histology, biology matters. That's why Bronny James is or was in the NBA, and my son hopefully will do well in school. So take home message, renal biology is the most important driver. Delayed intervention and dissemination is clearly linked to histology. A large indolent tumor is still indolent. A fast-growing benign tumor is still a benign tumor. We have many tools that we can use to characterize, and regardless of when you use them, either early or late, use them for any patient with higher treatment-related morbidity. Thank you.
All right, Brian, Maxine, and Eric remotely. Thank you guys. That was really engaging. We have time for a couple, if anybody has a question or two and wants to keep them brief while we ask our tumor board panel to please come up and take a seat. And I will tell you, I'm going to thank everybody. Oh, Laurence, go ahead.
So excellent session. I'm actually going to help with your tumor board with the first case. So yesterday I received an email from a urologist saying, we have this 31-year-old female that was recently diagnosed with FH germline mutation on the workup of uterine leiomyomatosis. And so part of the workup conducted to prompt both a CT and an MRI, which found an 18 millimeters, so less than 2 centimeters, tumor mass in her kidney. So my question to your tumor board is, how would you manage her?
Yeah. Brian, you trained at the NCI. I'll let you answer this one, but.
So biology matters. I don't care how big it is. I don't care how quickly it's growing. It's a potentially aggressive tumor. It needs to come out, and end of story.
And so which surgery would you go on for?
Yeah, I mean, a partial nephrectomy, but you have to be very careful. You have to take wide margins. We've had plenty of patients who have had, normal partial nephrectomy there, and they have, a nucleation or a very mini margin, and sometimes there's disease left behind, and it does matter for those tumors.
Thank you.
Yeah. Well, good. And I will tell you, just as an aside, Brian and I kind of putting this session together, the underlying message was size, growth, and histology all do matter, and these are things we take into account. So I'd like to thank you guys for sharing that. Yeah, I'm going to. So with this, we're going to start with our tumor board. We have 18 minutes. They put up on the clock there for us. So I'd like to introduce our panel, and we'll let everybody, you can see them all here. Allison May is a urologist at the University of Virginia. Adam Olson is a radiation oncologist at UPMC. Joe Pinero is at Fox Chase across town from me in interventional radiology. You guys met Maxine Tran already, a urologist from the United Kingdom, and Brian Shook from UCLA. So as part of this tumor board, just kind of the preparation disclosures, they don't know the slides, they don't know the cases. I might have forgotten some of the cases, so we'll kind of work through them together as we do this. There are no surprises here. We want to hear your discussion and your thoughts. Feel free to ask questions or clarifications. Nothing is meant to be a trick, and I would invite the audience, if you have a quick question that you'd like to pose to the tumor board as we go through these cases, please jump up and grab the microphone. We'd like your input as well, too. So let's start right away. Case number 1. Similar, Laurence, a little different, not a genetic predisposition here, but we've got a 42-year-old woman who's diagnosed with a 1-centimeter mass. She's super healthy, she's got normal kidney function and no family history of any renal tumors. You can see the imaging there. You see on the left kidney kind of that anterior midpolar 1-centimeter mass. Brian, let's start with you. What do we think this is, and what are you thinking about in her?
Yeah, young woman, small tumor, fat poor AML is something I'm thinking about, so I potentially would work her up for that and get more information. Maybe an MRI if the PET CT was available with girentuximab, that would be useful as well.
Dr. Pinero, I see you jumping at the bit there, yeah?
No, I mean, I agree, it's small. If we don't have any priors knowing growth rate, I think MRI is a good place to start.
These are ones that I've started calling in clinic indeterminate renal masses, right? Not even smaller, indeterminate. This is 1 centimeter. This, in a woman this age, 50% chance of being benign. I think we all kind of recognize this. So this was not my patient. She was diagnosed at an outside institution, and this was at a time, you'll see as the case progresses, where we were really interested in genetics in small renal masses and kidney cancer. So she actually had germline testing. I'll just ask you guys to raise it. Would anybody have ordered germline genetic testing for this patient? No. Well, you can see it there. But Brian, I'll put you on the spot again. You wrote a paper that has changed the guidelines where 46 and under kidney cancers, the guidelines now all recommend at least genetic discussions or discussions regarding genetic counseling. Tell us a little bit more of your thoughts, how that's evolved since you guys have wrote that paper.
Yeah, I mean, if you know nothing about the patient, you've never seen a hereditary syndrome, and you don't know what Birt-Hogg-Dubé is or how to spell VHL, it's very useful to guide patients for counseling. But not every patient who's under 46 that has maybe a solitary clear cell, Marie and this long group has shown that like 40 consecutive patients with a solitary clear cell under 46 in their experienced hands probably is not going to test positive. So again, it's worth the discussion. It's always worth consideration in someone who's young, but I don't send everyone for testing.
Okay. I'm going to go right down the road. I'll ask everybody next test or what are you doing? You got to pick one. A little bit like Woodfire here. Just pick one, Brian. What are you doing? MRI, biopsy, CT?
MRI and seeing if the fat suppression phases could show maybe there's microscopic fat.
Maxine?
I mean, it's 1.1 centimeters. I mean, our usual practice is just to reassure on, maybe do another scan in 6 months' time.
Alan?
Wouldn't jump in.
Yep.
Yeah, I agree. I'd probably do another scan in about 6 months. And I kind of like alternating CT, MRI if I'm not sure, so maybe an MRI in about 6 months.
Okay. Dr. Pinero?
I prefer MRI and agree. I would do a 3 to 6 month MRI.
Okay. Dr. Olson?
Same.
Okay. Nobody biopsied this. Nobody would biopsy this. Interestingly, this patient had a biopsy. So this was a low-grade papillary tumor. So now, what are we thinking? Anybody change their thoughts now that we have histology? 3 to 6 months? Okay. So here's her growth. This is her growth scan over the next 10 years. So she was 42 years old. She's now 52 years old. And you can kind of see, I put the imaging modality, and you see the gentle size changes. It stayed 1.3 centimeters over the course of 10 years. Anybody want to comment on this growth curve or changes or any of the imaging?
Yeah, I mean, again, this is an indolent tumor, but, to do 50 scans over someone's lifetime, I think, I would tell this patient, yes, we're going to follow it. I'm never going to not follow it. So these are some patients who I said, even though I think it's indolent, do you want to continue doing this every year or just want a pretty easy operation?
And could you guys just give us the ablation kind of strategies here? Quickly, cryoablation, microwave, Saber, what do you guys think for something in this location, this size? I can go back to the imaging if you want.
As far as ablation, I lean more towards cryo personally. Should not be an issue if everything made sense to treat. I would hydrodissect the spleen and the small bowel way. That, again, should be pretty straightforward. So it's small. It should be easy to get a complete response.
Yeah, similarly, the only subtle point on this is just ensuring that any of the adjacent small bowel is not too close to the SBRT, SABRE, pick your acronym, field, but it, again, should have a very, very high local control as evidenced by Fast Track 2 and many others.
And I'll just make the comment on this growth curve. You know, Eric, in his talk, made the comments about ultrasound sometimes over or underestimating growth, and I think you see that. If you look at the CT scans, this thing's incredibly stable on that, so don't get too excited over ultrasound changes. All right, 45-year-old woman, incidental diagnosis. Here's a slightly different renal mass. This comes to you being labeled a Bosniak 4 lesion. Allie, what do you think? Is this a Bosniak 4 lesion?
So this one's definitely a little bit larger. You know, it's hard to tell from just one cut here, but it looks, you know, concerning enough. It looks like a complex type of cyst. I would, you know, want to see more images or potentially get, you know, an MRI or ultrasound to characterize a little bit better.
Yeah. I think an MRI is a great start, right? Especially when you're trying to figure out cystic from solid, really classify these things. And I think also a really important note, make sure you look at your own imaging. I don't think this is a straightforward Bosniak 4 by CT scan, even though that report may say it. So look at your own imaging and it'll really help. So she says, I can't go to the operating room. I have no interest in surgery. So 6 months later, it now looks like this. 45 years old, what are we doing? I think this one's relatively straightforward for the surgeons. So I'll ask Dr. Tran maybe, what are your thoughts here?
Well, I haven't got the measurements, but just eyeballing it, it's significantly increased in size, hasn't it? So the way that we would probably consult her is if she's not willing or not keen to proceed directly to surgery, then perhaps a biopsy would help.
Gentleman at the far end.
Yeah, I agree, certainly. From just looking at this as a, you know, is this or is this not, you know, a lesion that could be treated with stereotactic radiation, for example? I think it's not only size but location within the kidney relative primarily to bowel that, you know, is part of the therapeutic ratio. But again, this is something that I think SBRT would potentially feasibly treat very effectively if she was either unable or unwilling to undergo resection.
And Joe, you know, this is not a one probe cryo. What are your thoughts?
Yeah, no, I mean, it's still very doable though. It's not approaching the hilum at all. The vast majority of the tumor is exophytic, and again, the bowel that's nearby, it's pretty easy for us to move with hydrodissection. So the only pause is there's not a ton of perirenal fat. So if I'm doing an ablation, I'm going to be extending some of that ablation into the surrounding musculature, so the patient may have a little bit more pain than another patient that does not have that scenario, but very treatable.
Okay. Yeah, these ones make me worried. Anytime they come in when they're talked about cystic masses and they don't look cystic, there's some really bad renal cell carcinomas that can masquerade like that. So this is someone you got to get to I think you get to the operating room quickly. All right, so we don't have answers on all of these, so that's why they're here. So here's a 43-year-old man with kidney failure, stage 4 chronic kidney disease, has bilateral renal masses. In retrospect, had a hematuria workup 5 years prior when his kidney function was a little bit better. He was found to have bilateral renal masses then, declined contrast at that point, and also declined follow-up. So now he is approaching end-stage renal disease. He's got a healthy sister who wants to donate a kidney, and you can see GFR. He's expected to be on dialysis within the next 2 years. Here are your non-contrast images. You can see kind of lobular kidneys. Next steps for everybody in the room, or Allie, why don't you tell us what would you do next?
So there's bilateral renal masses. He's already, you know, advanced kidney disease. Is he on the transplant list, I think you said?
He's got a living donor waiting for him.
Okay. So, I think if he's got a transplant available, it's very reasonable to discuss, potentially even nephrectomy at the time of transplant. I can't tell, but that there's a few that look a little bit larger on the left side. I assume they've grown if he's been, they were seen earlier. So I think that's very reasonable to discuss, removal at the time of transplant.
Okay. Maxine, any other workup at this point?
Yeah, I mean, I think because he's not dialysis dependent at the moment, so I think the stakes are still high. The longer you can keep him off dialysis, the better it is for his quality of life. So I would discuss either, if I had access to it, one of the nuclear medicine scans, girentuximab or cystoscopy or biopsy, which is the most simplest access that we've got.
So he actually had an MRI, and you can actually see, so most new gadolinium agents are safe at any GFR, so he had a actually contrast-enhanced MRI, and you can see the mass is a little more well clarified here. So 1.8 centimeters on the right, 4 centimeters on the left. Once again, anybody going to the operating room now?
Would anyone clear him for transplant?
That's a good question.
So I guess I think I was thinking wrong that he was already on the transplant list. I think you could look at trying to do potentially partial on that left side, see how that goes. But I think you have to have a really serious discussion at this point that the stakes are very high and the risk of dialysis and then progressing to transplant is large here. I know also there's a lot of controversy in the transplant rules here. He's got a 4 centimeter mass, so is that going to be something that they're willing to transplant with it, or are they going to want to watch that for a little while? So I think you have to have a really close discussion with your transplant team as well.
Yeah, I'll answer for the transplant surgeons. They will not allow him to be transplanted with a 4 centimeter mass that looks like that. The one on the right, they would watch, but the one on the left, they won't. Maxine?
Yeah, I was just going to say that they look different, don't they, on the MRI, and I think histology would be helpful in the form of biopsy.
I think ultimately you could also think, the ultimate histology is a nephrectomy here too. He is destined for dialysis. We all know the trepidation of initiating dialysis in an intraoperative or hospital setting, right? They're in the hospital for as long as a week or 2 weeks while they initiate dialysis. So this is one, you come up with a plan. We often talk to the nephrologist, sometimes prematurely initiating dialysis without a true indication just to get somebody ramped up and ready beforehand. This is a challenging one.
So this is my patient, so I know what happens. But I would just say that young people, we know these transplants don't last forever. So there is some benefit trying to delay transplant as long as possible because you don't want them to have 2 or 3 transplants in their life.
And then I'll ask you the other question, Brian, since you're a patient. So now he gets transplanted. So we've kept the kidneys in. He gets transplanted. He's on immunosuppression now. How does that change your thoughts about small renal masses on immunosuppression?
It doesn't. I've never seen it change biology. Disease biology is disease biology for small renal mass.
Okay. Anybody feel differently? I do. Yeah, so I think clearly in the small renal mass literature, immunosuppression doesn't make an impact, and I agree with you. Once you start getting in these large tumors, we know that you're walking a very fine line because metastatic renal cell carcinoma on somebody on immunosuppression is a very challenging diagnosis and very challenging management. So I would be very quickly to the operating room for that left-sided mass if he was transplanted. All right. So this patient actually underwent a partial nephrectomy. Brian did an amazing job and went home on post-op day 2. 2 years later, the right renal mass is now 2 centimeters. He starts on dialysis, gets a living donor transplant a year later. So just to kind of finish that story out. Maybe we'll get through another case or two. Here's a 73-year-old man. We've got a 3.2 centimeter lesion in a left pelvic kidney and a 4 centimeter Bosniak 3-4. We're just going to go right to management here. So this patient had biopsies of both masses. The right side was non-diagnostic twice, and the left side showed an oncocytic neoplasm most consistent with oncocytoma. give you guys a second to ponder, and then feel free to grab the microphone.
I guess, did we have growth rate on these, or these were just
These are brand new
initial
diagnosis, brand new diagnosed, had the biopsies, and now sitting in your clinic to discuss biopsies.
Phil, was this one of my cases that I sent you? Okay, I'll keep quiet.
So, I mean, for the right side, unfortunately, the biopsy is non-diagnostic. You could do a sestami spec CT just to kind of get more information from the left, but it doesn't really look like an oncocytoma. It looks more cystic solid, but I would probably also consider an MRI.
Yeah, once again, I think this is one of these challenging, this is clearly not a simple cyst, right? One with zero malignant potential, and I think that's in a really tricky location for a high-quality partial nephrectomy. So yeah, 6 months later, now your right-sided mass looks like this. The left-sided mass looks exactly the same. Brian?
Yeah, I mean, it's not getting bigger, but it's filling in, which is obviously concerning. So, I mean, I would get an MRI. I like to see the soft tissue characteristics, but, this is a case where we've done ones where if you have a nice enucleation plane, you could try to enucleate. I do worry about, ablating something this deep centrally. We've done it, but I would say that a lot of times they fail immediately. You could do SBRT as an option, and, we also have some newer radiation modalities that are in trials as well.
Yeah, I'll ask the far end of the table. Big central tumor like that. Joe, Adam, what are your thoughts?
Yeah, I think the prior discussion, the prior cases, you can sort of get a sense that there's a Venn diagram sort of overlaying kind of focal therapies, and whether it's SBRT or something else, or ablation or cryotherapy, and they're not like a perfect overlap. I think in this setting, kind of given the central location, SBRT, and then there's a decent plane to duodenum there, maybe a very reasonable treatment approach. That's kind of an umbrella radiation technique, but there are CT-based and MR-based linear accelerators that can both deliver this, and I think MR actually might be kind of a preferred modality for this, just for kind of better soft tissue resolution.
The one thing I would kind of go back to is from a diagnostic standpoint, I would look at the two non-diagnostic biopsy attempts, the imaging from them, just from somebody that does a ton of biopsies. There's a small area, maybe the needle was just poorly positioned. So I might even have offered a third biopsy at that time. I think biopsy is absolutely an option at the 6 month later mark. It's filled in. We should get tissue. I mean, that should get tissue. As far as treatment, I wouldn't do an ablation. Definitely wouldn't do microwave. Central lesions have higher urine leaks with microwave. And even with cryo, I'd be just too afraid of bleeding issues. Even though I'm not really as worried about the urine leak part, my ability to get a complete response is not going to be as great.
Okay. Brian?
Yeah, if I fail, we have one failed biopsy sometimes. Michael has a paper that the repeat biopsy rate is very accurate. This obviously failed twice. Sometimes what we do is we have a radiologist do contrast-enhanced ultrasound to try to see is there a viable part of the tumor that is enhancing, and then have them actually biopsy that. Sometimes if you biopsy and it's like necrotic area, you're going to miss it. So we found that to be very helpful to actually biopsy the good part of the tumor.
Yeah, I think this is another one of those tricky cystic masses, right? Is that true tumor growth, or is that old blood products that are layering from your biopsy? So I think an MRI is useful here, but I would lean on the side of having that kidney out. That mass scares me, to be honest with you. So that's the end of our time, so we'll just get to the objectives or the thank you. So this is complex and nuanced, as you can see from this panel of experts. We didn't all agree on what we were doing, so engage your colleagues, have discussions about these patients. We know the metastatic potential for these tumors is low, but we need to balance that against competing risk of death, comorbidities, and of course our patient preferences. So any questions or comments, and we'd like to thank you for your attention. Anybody? Mike Steller, you're awfully quiet this morning. Good. All right. Thanks, everybody. Oh, there he goes. I egged him on.
I just want to support you. With the SBRT, with those really centrally located masses, just because I think I'm the only one from the IROG here. You got to consider that over time, the vasculature might be damaged so that the whole kidney is going to go down. In a 73-year-old patient, that doesn't matter. But the 44-year-old, there's no data to support that we should do SBRT in those young patients. And that's one thing you should keep in mind choosing your intervention. This is not an intervention to treat a tumor. It's an intervention to treat a patient who is going to live for 40 more years, according to statistics. So do you actually have data to support that the intervention you're doing is going to give this patient tumor control for 40 years? And I think we don't have that with any of the ablation techniques other than cut it out.
Thanks, Mike. All right, thanks, everybody.